Hello, and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on sleep apnea under the section of respiratory medicine. So what is sleep apnea? By definition, it's an episode of complete absence of breathing during sleep. In terms of its epidemiology, it's the most common sleep disorder, is commonest among middle-aged men. It has a prevalence of about 4% in the population, and it's associated with increasing age, higher BMI, hypertension, GORD, and smoking. Just to get down to the details of sleep apnea so you guys can have a better understanding of things, in terms of its classification, it's technically classified into 3 different categories. The first one is obstructive sleep apnea, which is basically halting or stopping of airflow through nose or mouth due to narrowing and closure of upper airway with ongoing diaphragmatic and intercostal muscle activity. The second one is central apnea, which is stopping or halting of air without diaphragmatic or intercostal muscle activity. And the third one is a mixed apnea, which usually starts with episodes of central apnea followed by periods of obstructive sleep apnea. For the purpose of this video, we will be mostly concentrating on obstructive sleep apnea. Causes of obstructive sleep apnea are quite important for your MRCP examinations, and they can particularly come up as part of Station 5 in your PACES exam. These causes include conditions resulting in narrowing of the upper airway and or occlusion of the pharynx, which include mucosal edema and inflammation, for example, secondary to rhinitis, anatomical deformities secondary to microganthia, enlarged tongue, for instance, when you get with Down syndrome, and also structural lesions, for instance, enlarged adenoids or tonsils. The other causes include weakness of pharyngeal and laryngeal muscles, for example, as a result of vocal cord paralysis, cranial bone abnormalities, for instance, secondary to severe rheumatoid arthritis, increased airway compliance, which is the case in Marfan syndrome, and also infiltration of pharyngeal tissue that you most commonly get as the result of obesity. As for its symptoms, really these are the questions that you need to be asking as part of your history when the patient comes to the clinic or in the cases of PACES. And these include taking a history not just from the patient but also from patient's partner if possible. The symptoms that you want to be paying particular attention to include snoring, apneic episodes during sleep, restless sleep, nocturia, daytime somnolence, morning headaches, mood disturbance, reduced libido, and forgetfulness. Obstructive sleep apnea or OSA really is one of those things that you should be thinking about as you see the patient. And that include high BMI, increased color size, and that's for men more than 17 inches, for women more than 16 inches, history of hypertension, features of hypothyroidism, enlarged tonsils, and also congestive cardiac failure. The investigations that you want for assess someone for possibility of obstructive sleep apnea or OSA after taking a full history from the patient and their partner ideally, you would really want to go on and do an Epworth sleepiness scale, which we will be talking in the future slide. Then the next most appropriate thing would be doing an overnight pulse oximetry, which is basically when the patient wears a pulse oximeter at their own home and you will have their numbers recorded. However, the gold standard of investigations for obstructive sleep apnea is polysomnography or sleep studies. So this is what you will be asking in terms of the Epworth sleepiness scale. And as you can see, you will be giving this to the patient and asking them to fill it in. So they will be asked about their level of sleepiness and the chance of dozing at different situations. For instance, sitting and reading, watching the TV, and all the way down to in a car driving. The aims of the treatment in OSA really is surrounding three main factors. One is to provide symptomatic relief for the patient. The second thing is to provide symptomatic relief for the partner. And the third thing is to reduce the side effects of comorbidities that are associated with OSA, which we will be covering shortly. As a whole, the principle of treatment really is surrounding weight reduction, and if that's not possible or that's unsuccessful, you will be thinking about providing the patient with a nasal continuous positive airway pressure device. If the patient is non-compliant with that, you could possibly consider some dental appliances to basically try to keep the airway and the mouth open, and in the extreme of circumstances, you could potentially consider tracheostomy. However, that's something that certainly won't be expected for you guys at a level of an IMT doctor to make, and that's certainly a subspecialist interest. In terms of its complications, really that's where the money is in terms of your exam, especially for PACES. The biggest one that you do need to inform the patient, to inform the DVLA, is surrounding driving accidents, which is quite self-explanatory. If you think about if you have a patient who is constantly falling asleep during the day because they haven't had a restful night, then they would be putting themselves and other road users at risk. There is increased risk of all types of cardiovascular diseases such as hypertension, stroke, MIs, and also because of the narrowing of the airway, there is the risk of increased anesthetic complications. So that's something that you do need to make sure that your patient is aware of, and they also inform their anesthetist team for any future operations. Okay, let's do some questions. Question 1 is a 65-year-old man with a BMI of 30 who presents with his partner to the respiratory clinic. He reports a 6-month history of fatigue and daytime somnolence. On speaking with the partner, it appears that she also has poor sleep due to being awakened by snoring sounds. Given the likely diagnosis, which of the following is the optimal confirmatory test? So the options are A, Epworth sleepiness scale, B, color measurement, C, polysomnography, D, overnight pulse oximetry, and E, pulmonary function test. So going back to the question, hopefully this is all ringing alarm bells for all of you that this is a classic case of obstructive sleep apnea. You've got a middle-aged man who is significantly overweight, is coming to the respiratory clinic and is complaining of daytime tiredness, and also very helpfully his partner is also there who tells you that she keeps getting up because of him snoring throughout the night. So really getting the diagnosis of OSA is the easy part in here. Now the question is asking you about the optimal confirmatory test, i.e. the gold standard. This is not asking you about what's the first appropriate investigation to start, and because it's asking you about the confirmatory test, the gold standard confirmatory test, as you know, for obstructive sleep apnea is option C, which is polysomnography, which is basically sleep studies. So they would be admitted overnight to a sleep lab in a controlled environment. They would have all sorts of various different measurements taken, from pulse oximeter to saturation level to heart rate and brain waves. However, as mentioned before, please be careful if they ask you what is the first investigation that you would be due to assess the underlying cause. Obviously, that would be a bedside, quite an easy and accessible test such as Epworth sleepiness scale. Thanks for listening to this episode of Bite-Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.